Okay, so let's talk a bit about congestion more. Um, what's
All
going
right.
on inside the lungs, in the alveoli, in the ankles? Tell us how gravity affects this and in the hepatic portal system.
Congestion affects different areas based on where blood flow backs up, with gravity playing a role. In the lungs, congestion often stems from left heart failure, where blood can't be pumped out efficiently. This increases pressure in pulmonary veins, pushing fluid from capillaries into the alveoli, causing pulmonary edema, making breathing difficult. In the ankles, congestion, often from right heart failure or venous insufficiency, leads to blood pooling in lower veins due to gravity, especially when standing. High hydrostatic pressure forces fluid into tissues, causing swelling or edema in the ankles. Gravity worsens this in dependent areas like the legs, as blood struggles against it to return to the heart. In the hepatic portal system, congestion can occur from liver issues or right heart failure, where blood backs up in the portal vein. This raises pressure, leading to fluid leakage into the abdominal cavity, acides, and swollen liver. Gravity doesn't directly affect the portal system as much, since it's internal, but systemic congestion amplifies the issue. Want to dive deeper into one of these areas or something else?
Well, so let's talk a bit about pH now. We've got a lot to talk regarding hydrogen ions, bicarbonate, and CO2. Explain us, make a nice system to explain us how these connect to what we're talking about with acid-base balance.
All right, let's connect pH, hydrogen ions, bicarbonate, and CO2 to acid-base balance in a clear system. Blood pH, ideally 7.35 to 7.45, is tightly regulated to avoid acidosis, too acidic, or alkalosis, too basic. Hydrogen ions, H plus minus, determine pH. More H plus lowers pH, making it acidic. Fewer H plus raises pH, making it basic. CO2, produced by metabolism, combines with water in blood to form carbonic acid, H2C3, which breaks into H plus and bicarbonate, HCO3 minus ion sigma. Bicarbonate acts as a buffer, soaking up excess H plus to stabilize pH. The lungs control CO2 levels by breathing it out. Faster breathing reduces CO2 and H plus, raising pH. Slower breathing retains CO2, lowering pH. The kidneys fine-tune
So,
by reabsorbing or excreting bicarbonate and H plus ions. In congestion, like in lung edema, poor gas exchange can trap CO2, increasing H plus and causing respiratory acidosis. In contrast, kidney issues from congestion might impair bicarbonate regulation, leading to metabolic acidosis. The system works together. Lungs handle CO2, kidneys manage bicarbonate, and both balance H plus to keep pH steady. Want to zoom in on how congestion messes with this or another angle?
why don't we talk a bit about acute kidney injury and if it's going to cause metabolic acidosis and a difference in the anion gap? But also, let me clarify. So you say that high CO2 means low pH, right?
Yeah, exactly. High CO2 lowers pH because CO2 combines with water to form carbonic acid, which splits into hydrogen ions, H plus, and bicarbonate. More CO2 means more H plus, making blood more acidic, lower pH. Now, acute kidney injury, AKI, disrupts the kidney's ability to excrete H plus and reabsorb bicarbonate, often causing metabolic acidosis, low pH, and low bicarbonate. In AKI, waste products like acids build up, increasing H plus. The anion gap, which measures unmeasured anions like lactate or sulfates in blood, helps identify the cause. A high anion gap in AKI often points to acid buildup from things like lactic acid or uremic toxins, common in severe injury. A normal anion gap might suggest bicarbonate loss instead. So, AKI typically triggers metabolic acidosis, often with a high anion gap due to accumulated acids. Want to dig into anion gap details or AKI's impact further?
To be honest, I didn't completely catch that part with the anion gap and the metabolic acidosis. If you could repeat it in 2 sentences, make it nice and understandable.
Acute kidney injury can cause metabolic acidosis by impairing the kidney's ability to excrete acids and reabsorb bicarbonate, leading to low blood pH. A high anion gap in this case often indicates a buildup of unmeasured acids, like lactic acid, while a normal gap suggests bicarbonate loss. Want to clarify anything else or move on?
Yeah, diuretics. Loop, thiazide, and potassium sparing. How will I ever remember that spironolactone is potassium sparing, furosemide is loop, and thiazide is indapamide? Well, indapamide is a thiazide diuretic. Because I'm not good with remembering arbitrary information. You know, like I know a computer, you say to it 001010011111 means move up in a video game or whatever. But I can't accept those correlations like that, you know? Because
I hear you.
Yeah, sorry, tell me.
No sweat. Let's make diuretics stick without feeling arbitrary. Loop diuretics, like furosemide, work on the loop of Henle and the kidneys, flushing out lots of water and sodium fast and powerful. Think furosemide floods. Thiazide diuretics, like indapamide, act on the distal tubules, reducing sodium reabsorption more gently. Picture indapamide is milder. Potassium-sparing diuretics, like spironolactone, block aldosterone's effects, so they keep potassium while still promoting water loss. Think spironolactone saves potassium. To remember, furosemide, loop, is a heavy hitter, indapamide, thiazide, is smoother, and spironolactone, potassium-sparing, protects potassium. Tie them to their actions, not random codes, and it feels less like a computer command. Want tricks to lock these in, or more on how they work?
Why don't we talk a bit about hypertension and renal tubule failure? So there are a few types of tubule failure, if you could get into that. And I don't understand why this metabolic acidosis, specifically renal tubule failure.
All right, let's connect hypertension, renal tubular failure, and metabolic acidosis. Renal tubular failure, often called renal tubular acidosis, RTA, involves the kidney's tubules failing to properly handle acid-base balance or electrolytes. There are 3 main types. Type 1, distal RTA, is when the distal tubules can't excrete hydrogen ions, H+, leading to acid buildup and metabolic acidosis. Type 2, proximal RTA, is when proximal tubules can't reabsorb bicarbonate, causing bicarbonate loss in urine and, again, metabolic acidosis. Type 4, hyperkalemic RTA, is linked to low aldosterone or aldosterone resistance, impairing H+ and potassium excretion, resulting in milder acidosis and high potassium. Hypertension can contribute to tubular damage over time by stressing kidney blood vessels, reducing blood flow to tubules, and causing chronic injury. This can worsen or trigger RTA, especially in chronic kidney disease. Metabolic acidosis in RTA, particularly types 1 and 2, happens because the tubules can't remove H+ or retain enough bicarbonate, lowering blood pH. Type 4 is less severe, but still acidotic due to impaired acid excretion. Unlike acute kidney injury, which often raises the anion gap, RTA typically causes normal anion gap acidosis because the issue is bicarbonate loss or failure to excrete H+, not an accumulation of unmeasured acids. To make it clear, hypertension damages kidney tubules, leading to RTA, where tubules fail to balance H+ or bicarbonate, causing metabolic acidosis with a normal anion gap. Want me to simplify further or dive into a specific RTA type?
Let's talk a bit about just a sec. Let me find it. Okay. And our second topic, which is red blood cells. So what's going on? What are red blood cells? And perhaps introduce us to the idea of blood gas transport too while you're at it.
All right, let's clarify and dive in. I think you meant arterial console as arterial content.
No, I said what's red blood cells, and then I said explain to us blood gas transport while you're at it. How hemoglobin is like a taxi. When there's a lot of people, it kind of, gets some people and then drops them off in their house, which is like in a rural area almost. That's a nice analogy.
Got it. Let's break it down. Red blood cells, RBCs, are disc-shaped cells packed with hemoglobin, a protein that carries oxygen and carbon dioxide in the blood. They lack a nucleus to maximize space for hemoglobin, and their job is to transport gases to keep your body running. Now, for blood gas transport, think of hemoglobin as a taxi. In the lungs, where oxygen is plentiful, like a busy city, hemoglobin picks up oxygen molecules, binding them tightly to form oxyhemoglobin. The RBCs, like taxis, carry this oxygen through arteries to tissues, where oxygen levels are lower, like a rural area. There, hemoglobin drops off oxygen for cells to use, as the lower oxygen environment makes it release its load. On the flip side, hemoglobin picks up carbon dioxide, CO2, a waste product from tissues, forming carbaminohemoglobin, or binding it indirectly via bicarbonate. It then taxis CO2 back to the lungs to be exhaled. The analogy fits. Hemoglobin loads up passengers, oxygen, in a busy area, lungs, drops them off in quieter areas, tissues, and picks up new passengers, CO2, to return to the starting point. This keeps gas exchange efficient. Want to explore RBC production or dive deeper into hemoglobin's role?
I want to understand the concept of cooperativity and how exactly hemoglobin is carrying things.
All right, let's tackle hemoglobin's cooperativity and how it carries gases. Hemoglobin, inside red blood cells, is a protein with 4 subunits, each able to bind one oxygen molecule. Cooperativity means that when one subunit grabs an oxygen molecule, it changes hemoglobin's shape, making it easier for the other subunits to bind oxygen too. This creates a snowball effect. The first oxygen is hard to bind, but each additional one gets easier, so hemoglobin loads up quickly in the oxygen-rich lungs. In tissues, where oxygen is scarce, the reverse happens. Releasing one oxygen makes it easier to drop the rest, ensuring efficient delivery. For how it carries things, hemoglobin binds oxygen to its iron atoms, forming oxyhemoglobin, carrying up to 4 oxygen molecules per hemoglobin. It also carries carbon dioxide, but differently. About 10% binds directly to hemoglobin's protein parts, not iron, forming carbaminohemoglobin, while most CO2 dissolves in blood or converts to bicarbonate for transport. Cooperativity makes hemoglobin a smart taxi, loading and unloading oxygen fast where it's needed most. Want to dive into the Bohr effect or something else?
Well, we are going to dive into the Bohr effect for sure. I want to understand also the right shifting of the binding curve. And yeah.
All right, let's hit the Bohr effect and the right shift of the hemoglobin oxygen binding curve. The Bohr effect describes how hemoglobin releases oxygen more easily in tissues when pH is lower, more acidic, or CO2 levels are higher. In active tissues, like muscles, CO2 from metabolism raises acidity, more H plus ions, which weakens hemoglobin's grip on oxygen, so it unloads oxygen where it's needed most. This is key for efficient delivery. Now, the binding curve shows how hemoglobin binds oxygen at different oxygen pressures. A right shift means hemoglobin holds oxygen less tightly, releasing it more readily at lower oxygen pressures. This happens with higher CO2, lower pH, higher temperature, or increased 2,3-BPG, a molecule in red blood cells. These conditions, common in active tissues, shift the curve right, boosting oxygen delivery. So, the Bohr effect drives the right shift by making hemoglobin more responsive to tissue needs. Want to clarify the curve further or explore 2,3-BPG's role?